just going to discuss, there was two packages that looked at gathered numbers, quantitative data, one from a prevalence study and one from secondary analysis. And I'm going to try and bring them together and hope this will finally be the kind of final kind of piece of the puzzle. So the reason we did a prevalence study, we did this before the case studies, is that as we've already indicated, the significant mental health needs identified uh, from people who use sexual assault referral centres. But they're often single site studies that are published that we found in the literature. So we wanted to screen a larger sample across several SARCs. We also want, and this is back to that question about what happens to people. We wanted to do a 6-month follow-up to address exactly that. We wanted to reassess people's mental health and substance use at 6 months follow-up, and we wanted to look at their service use and have those referrals happened and how useful they've been. And sadly, because of all the COVID delays, we had to scrap the 6-month aspect of the study, which was a real shame. And hopefully we might get to do something at another point, but it would be a very worthwhile study to just kind of see what actually happens following this over a few months or even up to a year. Okay, so how we recruited people for this. This is only people who'd attended the SARCs who were participants. SARC staff mentioned the study to potential participants, email, telephone, or face-to-face, and they obtained consent to contact, which was then passed to us. So that was basically the person giving permission for the SARC staff to tell us about their contact details. And then one of our MEMOS researchers, of which Dora was one, would then attempt to get in touch. And we obviously didn't over-egg this. If we couldn't get hold of someone after a few attempts, then we left people be. Obviously, it's a difficult time for people. But if they did make contact, they were advised about the study aims and what was involved. They could ask questions, and everyone got a fully detailed information sheet, and everyone received a £10 online voucher for completion of this. So what did we ask? We had an online survey. We would have done this face-to-face, but sadly COVID. So we converted it rapidly to an online survey, which was then emailed to the person. And data was collected not around the time of the visit to start. We allowed at least 1 week to pass before we would collect the data. So we wanted a little bit of a gap between that initial visit but we wanted it to be fairly recent to that visit. So we used Core 10, which is about psychological well-being. Audit C's an alcohol screening tool. We screened for PTSD. We looked at quality of life for the requal. We looked at a drug alcohol screening tool, and we screened using for SAPAS, which is a screening for personality disorders as well. We worked with our lived experience group to design the safety protocol. Everyone was told prior to taking part that the researcher would look at their responses online. We had access to the data, and we would look at how people were scoring on particular mental health scores, and if there was an issue, particularly around risk of suicide or hopelessness, then we would do a safety check, which was a follow-up call. And we did this on several occasions, and we actually advocated for people to get a call back from their GPs on a few occasions as well. All safety procedures were followed. So we collected data over about 8 months. We got a total of 236 consent to contact, which sounds like a lot. We didn't get this from all of the sites. Some of the SARCs did not recruit. 2 of the SARCs weren't able to recruit anybody for this particular aspect of the study. Of those who made contact with, 67% agreed. Sorry, I've got a typo there. 67% agreed. We made contact with 67 on half of those consented to take part. So we ended up with about 78 people took part in the survey. And in terms of demographics, they were mainly young. They were mostly female. 6 were identified as male, 3 identified as trans or non-binary. 73% were straight, 8% gay, lesbian, 19% as bisexual. And then we had a range of ethnicities with 65% white, and a range of other ethnicities, including Asian British, Black Caribbean, Black British, Black African as well. We looked at the national SARC data, broadly representative sample. We had slightly more Black and ethnic minorities than the national picture, and a slightly younger, but that might reflect that quite a few of our respondents came from the London area as well. So 64% had pre-existing mental health issues. So already in services, already engaged. The most common condition was depression, anxiety, and they were mainly getting help from primary care and were prescribed anxiolytics, which is for anti-anxiety meds and antidepressants. 9% reported being under the care of the secondary mental health service, which indicates a more severe and enduring mental health problem. 15% had self-reported problems with drugs and alcohol, with one person on methadone, 3 on crack cocaine, 3 using cannabis, and 2 had alcohol issues as well. So this is the main findings of this screening. And as you can see from that data, we had really high levels of mental health need from the screening tools. So 76% of that group scored in the moderate to severe range of the core 10. 12% scored between 8 and 15, which indicates increasing risk of alcohol problems on the audit C. 94% screen positive for potentially for PTSD. So just to say, these screening tools are a kind of indication which would then need a more thorough psychiatric interview to confirm. 87% were in the clinical range for low quality of life, which means that's typically what you would see from a clinical population within mental health services, pretty low quality of life. Nearly half had moderate to severe health problems, self-reported. 26% had moderate to severe, screened for moderate to severe drug problems, and 63% screened positive for personality disorder as well. So we were able to extrapolate that data from the national SARC data, and that list below, which we won't go through, you'll see we've tried to extrapolate how many people nationally, if that pattern is correct, how many people would have those needs on the national picture as well. So this is the first multi-site screening study of SARCs. We actually had five sites. We demonstrated safety and feasibility of screening tools. As I've said, I'm not going to go through this again, but we were significantly impacted by the COVID pandemic. So we didn't engage. We wanted 360 and we got 78. So you can see that it really did not hit our targets at all. However, we got high rates of mental health and substance use, which are much higher than reported in previous studies. But bear in mind, our data collection was during the height of the pandemic. 2/3 of participants already were in receipt of mental health care and substance use. We're wondering whether there could be a selection bias. It's like, do people who have mental health problems were more likely to agree to take part in our study? But actually, one of the main reasons for declining was people saying, it's my mental health, I don't feel like doing it. So I'm not sure about that. We'd need to maybe repeat it again now the pandemic as well. I say the pandemic's passed, but the main issues have probably resolved. We used self-complete screening tools, not standardized psychiatric. So this data is a screening. It doesn't say for definite people have these issues. And there's always potential for these rates to be overinflated, especially given that it's a time when people are under quite a lot of stress anyway. We'd need to I'd love to have been able to do that follow-up to see what happened to those rates over time as well. Okay, so I'm just going to move on to the secondary data analysis. This is the final PowerPoint, so please bear with me. The final work package was a secondary analysis of a database called CRIS, which is basically care records that's anonymized and sucked into another place, and that is then through permissions you can access that anonymized data set for research purposes. So we got permission to do that, and that's what we did. And within that data set, we identified a group of people with a record of sexual assault in their care records, and a sort of matching group where they didn't have sexual assault recorded. And obviously, this is secondary data; it's routine care. it's always going to be limited, and there's potential that the 257 who didn't have a recorded sexual assault doesn't necessarily mean that they didn't. But anyway, so those with a sexual assault were significantly more likely to be female, less likely to be white, and more likely to live in deprived areas compared to those without a documentation of a sexual assault. So the overall aims was to assess changes in psychological well-being amongst males and females who experienced sexual assault that received psychological treatments from a mainstream mental health service. The interesting outcome was the results of the core OM, which is similar to the core 10, and it's about measurements of psychological distress. Keyword texts were used to identify cases. They were hand checked, which was incredibly time consuming and laborious, but we needed to check if the keywords blew up some cases. We needed to then check that there was definitely something there, and then we compared them basically quite descriptively really on therapy outcomes and number of sessions as well. So the findings, I've already mentioned the sample, but the mean scores were on the course, remember this is psychological distress, were much, much higher at baseline. So that's pre-therapy in the essay group, indicating more severity at the start of any treatment. Those in this essay group had a greater number of weeks of pre to post therapy. So that means a kind of longer treatment span, and they had more sessions. They were more likely to have diagnoses in the range of psychosis, severe mental illness diagnosis than the non-SA group, and 82% of the SA group had at least one risk assessment recorded, and as a group scored significantly higher on recent and non-recent risk factors, including previous suicide attempts, overdose, historic acts of self-harm, alcohol and substance misuse, current deteriorating depression with distress, and a significant anniversary, which are all things that would be ticking that risk assessment tool as well. So this SA group were twice as likely to have had more than 3 spells of care. So that's 3 episodes of care over the period we were looking at. The number of psychological therapy sessions were greater, and they had over 20 therapy sessions compared with 33 of the controls. The first diagnosis was the year of first diagnosis was earlier in the SA group, and they received significantly more diagnosis, which is interesting. I'm sure people will have questions about that. I certainly have some views on that, about pathologizing distress, but I'm sure we'll get into that in the Q&A. And overall, 45% of the SA group had 4 or more diagnoses compared with 22% of the controls. So in terms of discussion, it's not an easy task to identify. It's a question, should we be routinely inquiring in mental health services? I personally think we should, but how you do that in a way that's trauma informed is another question as well. It's also about where it's recorded and how it's recorded. We don't have, and sadly, and this is a question some of you may have, we didn't have any information about those with a recorded essay had ever been to a SARC or actually pursued anything around that sexual assault as well. We didn't have that information. We also don't know if the therapy they received was connected directly to the sexual assault, or the sexual assault was something in their past that may or may not be connected to why they were seeking help as well. The positive message, though, and I think it's a really positive message, is despite starting out much more distress, much more severity of distress, people with a history of sexual assault can and do benefit from psychological therapies, but they did seem to need more sessions and more episodes of therapy. So this is something that echoes what in the case studies, when people said, I was referred to some generic like 6 sessions and that was it, and didn't find that particularly helpful. It feels like people need maybe a bit more help for a bit longer as well. So that's the presentation's over. This is just my final messages really from everything that we've heard this evening. And it's just a real sum really, that there's high levels, I think we've established there's high levels of mental health and substance use needs in people who attend SARC. Many have pre-existing conditions and already in receipt of care. I don't know if the people in mental health services or substance use services, whether how much their care workers know about the sexual assault referral centre episode as well. So there's lots of mismatch between that. We know that sexual violence can lead to acute distress, and for some, and not everybody, for some can lead to more longer term mental health issues, especially PTSD. The mental health and substance use aspect of SARC services is clearly undeveloped. There's a lack of trained staff, there's an absence of screening tools, there's very minimal co-located services and really quite underdeveloped local service care pathways. However, SARCs do consistently use a trauma-informed approach, which helps survivors in their recovery journey and minimises re-traumatization. I think the SARCs could teach other services a lot about that approach. I think that's really important to say. There's significant gaps in service provision, long waiting lists, lack of specialist support, and lack of expertise in sexual violence in mental health care, and a lack of attention, to be honest, I think. When people do access therapy, our secondary analysis indicated as more severe needs, they may need longer treatment, but they do show improvement as well. So I think that's really important to finish on that one. So thank you for listening, and it's time for some questions. So I will stop sharing my screen.